So now I want to introduce a very good friend of mine. Remus Frei is the deputy lead of our endoscopy unit in St. Gallen. He's also senior lecturer at the medical school of the University of St. Gallen. And he leads the endoscopy group of Switzerland and is one of the main contributors to the expert opinion statements. So Remus, the floor is yours, and we're happy to have you here. Thank you.
Thank you very much, Jan, for this kind introduction. And Stefan, thank you very much for the invitation to this exceptional symposium. Thank you very much. So I will talk about endoscopic vacuum therapy, EVT, or endoluminal vacuum therapy in the next 25 minutes. What is the background? The background is that esophageal perforations and anastomotic leakage, especially after upper GI surgery, lead to a high morbidity and mortality. And we know from a bit of data probably that EVT has emerged as a useful tool with high efficacy. And from human and animal studies, we know that the negative pressure therapy contracts wound edges, removes exudate, including inflammatory and infectious material. We see this when we change the sponges. It promotes angiogenesis and it stimulates tissue granulation. These are all facts that perfect healing needs, and the negative pressure therapy promotes these factors. And so we get data for success rates of about 80 till about 90% for vacuum therapy in these patients. But those who fail, 10 to 20%, what do we do with this? And I will present and share with you a case where endoscopic therapy actually failed. And we will probably ask, why did it fail in this patient? This is the patient. He is not yet 50 years old, and he was diagnosed cancer of the GE junction, a T3 tumor, nodal positive, and he was treated in a curative intention with neoadjuvant radiochemotherapy. You see the regimen. And he was operated with a robotic-assisted minimal invasive esophagectomy at the end of February. And it's also important to mention the timeline. These patients with these complications that we discuss now, they are a very long time in hospital, they are very sick, and they have a lot of complications. So the definite histology of the tumor was YPT3, YPN2, L1. So a high-risk situation for recurrence after surgery. Everything went fine till 2 weeks. He was in hospital, and then he developed fever and a rise in CRP. And we did that gastroscopy, and what we saw, you see it on the left picture, you see a leak on the right upper quadrant. And what we first did is we inserted the EsoSponge for endoscopic vacuum therapy. What is EsoSponge? For those who are not very familiar with this therapy, I show how this works. So on the left picture, you see how the EsoSponge comes. It's an overtube. It's a pusher. So you place the sponge through this overtube, via this overtube with the pusher. Then you see the sponge with the sucking catheter, and there is a device to connect the vacuum pump. You usually have to cut the sponge a little bit so that it can be easily pushed through the overtube. So it makes it easier to position it correctly. And after the positioning, you attach the vacuum pump with usually a continuous suction of 125 millimeters of mercury. Usually change it every 3 days. What is data that we have on this therapy? And this is a study, Endoscopy 2023. And Stefan, you also took part of the study. 27 patients with iatrogenic perforations, Perhave, and 2 trauma. And a very high success rate of 89%. And what you see is the median number of sponge exchanges low, it was 1, but the median duration of EVT in days was 12 days. Failure, 3 patients. And we will have quite a straight look at these patients who failed. What was the problem there? EVT failed in 3. This is what I mentioned before. One patient died due to a septic embolic stroke, so a complication of the complication. One died due to pulmonary embolism, the one that 4 and the other 14 days after the negative pressure therapy. And one underwent esophagectomy because the defect showed no improvement under therapy. And this patient, as I read, had quite a long delay until the defect was recognized and then treated. And delay seems to be an important factor for success or not. And one patient died 8 days after completion of successful EVT, most likely to a cardiac cause. So these patients who have esophageal cancer and resection, they usually not have this alone, but they have comorbidity. This is the largest series that was presented at the ESGE days. It comes from the Spanish multi-center register. And it was presented at the ESGE days in spring in Dublin. And I present this data here. 102 patients, indications, surgery, obesity surgery, you see it here, Berhave, endoscopic perforation, Senker, diverticulotomy, and some others. The location, the main is thoracic or abdominal, some cervical. Prior therapies, resurgery, fully covered metal stent, and clips in 3 patients. What are the results? Closure of the defect, 84%. That's what we saw in the other study as well. So a little bit more than 80%. And we see a difference between perforations and anastomotic leakage after surgery. And there seemed to be a difference. This seemed to be a different population. And what I also want to mention is this fatal bleeding of an aortoesophageal fistula. So we have to be aware that when we place the stent extraluminal in a cavity, when there is a large defect and we have to place the stent in a cavity, we have to make sure afterwards where the sponge is definitely placed. Because endoscopically we can hardly say where we are. If we go into the defect, we go into the mediastinum, we hardly can say where we are. That's why if we have to place a sponge out of the lumen, we usually make a CT scan, at least the first time we put the stent there, to make sure where the sponge actually is. And so we can probably avoid this this complication, because when you suck the aorta, this will be a fatal complication. What did we do with our patient? We had a problem. As we wanted to apply the negative pressure, it was impossible. We couldn't get any negative pressure. Why? The CT showed why. We had a fistula. And we had actually a fistula, you see it here, from the esophagus to the main right bronchus. That's why we sucked the air from the airway, but we couldn't get any negative pressure. You see it here, the fistula, and you see here the defect. What did we do? We put a fully covered metal stent to seal the fistula. What does the data say about that? This is the updated ESGE guideline, the guideline of our European Society of Endoscopy, how we should proceed. And it said, recommends temporary stent placement can be considered for the treatment of leaks, fistula, and perforations. Strong recommendations, low quality of evidence. And what it also says is that the treatment should start as early as possible. So don't give any delay. So if you see it, treat it. Or if you recognize it, treat it. So strong recommendation, but very few data, obviously. And I searched for the data. What is the data? And I found this review. Stents in the treatment of leaks and esophageal perforations, systematic review. 66 studies, 1,700 patients. Success rate high, almost as high as with the sponge, which I could hardly believe. Multivariate analysis showed lower rates of clinical success in patients who had fistula and an orifice size of over 2 centimeters, which means if we have a large defect or we have a fistula, the therapy seems to be less effective. And then I wanted to know how many patients actually had a fistula. I couldn't find out. Then I searched for more data consisting with our problem with fistula. And just a little bit for this, for the stent therapy. The technical success here. And what I wanted to focus with this is the migration rates, 16%. This is what we know from the stent therapy, from the fully covered metal stents anyways. So the stent, they migrate, and they have a lot of re-interventions. So that's what we know from stenting with fully covered metal stents in other situations as well. This study focused on tracheobronchial fistula after esophageal resection. The study is 10 years old, but this is the largest series that I found, actually. And there were 222 patients that they were operated for esophageal cancer, and 7 of them, 3%, they developed fistula to the airway fistula. 4 of them had endoscopic stent implantation, 2 had surgical re-exploration because the fistula was accompanied by necrosis, which couldn't be handled conservatively. Closure of the fistula was achieved in all cases, and 1 patient died due to respiratory failure. So if we count these patients, we get of less than 50% that were saved by actually stenting. So this is the data that I found. How did it go on? So we wanted to remove the stent after 6 weeks. The ESGE guideline doesn't give us a straight guideline. How long do we have to stent? But we know that 6 to 8 weeks is probably the right time to remove. Everything fine, CRP, low, patient in good conditions. CT scan, you see it on the left, the fistula has gone. So everything fine? Probably not. As I introduced in the introduction, we were not actually successful with the treatment. And this is how it looked like after stent removal. You see here the fistula that we treated from the beginning. It didn't change at all. And if you look through the fistula, you can straightly see on the right main bronchus. What did we do? These patients are extremely complex, and I want to show this with this picture, with this image on the left-hand side. So we made a rendezvous, pneumology, gastroenterology. So from the pneumology side, they put in an airway stent, a Y stent, to cover the fistula from the airway side. And we put it a stent. You see the picture on below. You can see the airway stent through the fistula from the esophageal side. Then we put the sponge, and we changed it every 3 days, as we usually do. What happened? Almost nothing. And we had the problem to actually keep the negative pressure, because depending on the position of the patient, the stent of the airway stent could actually close the fistula, and in another position not. And so it was impossible to get a continuous negative pressure. This was probably the problem, or one of the problems here. So not effective. How did we proceed? We put this new kit on the block, which is this VacStent. And the VacStent, I show you afterwards, is an over-the-wire stent, a fully covered stent system that is positioned like a normal fully covered metal stent. And on the right-hand side, you see after we deployed the stent, you can see the endoscopic control of the correct position of the stent. And you also see the blue. This is the sucking catheter, where you apply also continuous pressure from 75 to 125 millimeters of mercury. These are details of the stent. For those who are not familiar with it, the stent comes in a box like this. It's an over-wire system. You use a 0035 guide wire, and it's quite a large diameter. The tip of the stent has 40 millimeter diameter, and this is the stent. The total length is 70 millimeter. The diameter of the stent itself is 14. The length of the sponge is 5, and the tulip is 30 millimeters. A technical detail is that you have to put a lot of water when you insert and when you want to deploy the stent. Otherwise, it's hard to to deploy the stent. So you have to get another, it's just a technical trick. And then you get the continuous negative pressure, as I mentioned, and you change it every 5 to 7 days. Very important, patients can eat and drink. And this is very important, especially for our patients. They are like in hospital for 3 months. And this gets a mental problem for a lot of these patients. So mental health is really a question for them. And eating and drinking, they helps them to keep to stick to the therapy. VacStent in the treatment of esophageal leaks. This is a very recent study. A few patients only, 15 at 3 centers, a total of 41 VacStents were actually placed in 15 patients, and the leak healing rate of 80%. So a number that we know from the sponge therapy as well. Septic episodes were prevented in 93%, which means that 1 patient had a septic complication, and there was no mortality. 1 anastomotic stenosis was seen during follow-up. And what I want to focus on in this study is the oral intake of liquids. Almost 90% of the patients, they could have oral intake, at least of fluids, which is very important for these patients. And intake of solid food, at least half of the patients, they could eat, which helps them to stick to the therapy, to be mentally healthy in this long period, which is very heavy for this. So, what did we recognize when we changed the stent? It was not that what we expected or not what we expected. This is the course after 1, 2, and 3 changes of the sponge. There was actually a novel fistula at the tracheal side, so proximal to the first fistula. You see here on the left-hand side, this is the airway stent, so the main duct of the airway stent to the fistula to the trachea. And here you see the fistula we treated from the beginning. So we had actually progressive fistulizing disease after or under therapy with sponge and stent. So it didn't work. And this patient will have to go for surgery in the next days. What can we do? Can preemptive use of such a negative pressure therapy, could this be an option? This is a study that I found in the Annals of Surgery. Retrospective analysis of 67 patients, almost all, 85% were high-risk patients. You see it there. Healing, direct healing, 37% after 1 course of sponge. Prolonged EVT, again healing in 13 patients. 1 uncontained leak with proximal gastric necrosis had to go for surgery. And the overall leak rate was 7.5%, which is low for these patients. And they compared it to a benchmark, cohort which have not had endoscopic vacuum therapy. So this is a cohort where benchmarks were defined. And in this benchmark cohort, the anastomotic leakage rate was 16%. So it could be dramatically reduced through a preemptive use, or prophylactic use of a sponge, which was placed during the operation, during the resection. In conclusion, endoscopic or endoluminal vacuum therapy seems to be very effective in treating leaks and perforations. In the upper GI tract, that's what I showed. I didn't give you the data about the lower GI tract, but in the lower GI tract, the data are very comparable to those in the upper GI tract. The VacStent is a new kid on the block, enables oral food intake, and this is very important for these patients, that they can even drink, or at least drink, or even eat a little bit. Limits, large leaks, fistula to the airway. These are very complex patients, and they need an individual approach. Cave, delay. It seems to be true that delay, as longer as we wait or as we recognize the defect and the later we treat it, the worse the outcome is. And the preemptive use can be helpful in high-risk patients. And with that, I thank you very much for your kind invitation. And as others said, I would like to invite you kindly to St. Gallen, which is also a beautiful place and not that far away from here. And we have a beautiful symposium, not as beautiful as yours, Stefan, but it's also beautiful. And covering different aspects of hepatology, IBD, and of course endoscopy, and at the end of October. So you're warmly welcome there. Thank you very much for your attention.
Thank you, Remus, for this invitation. I agreed already. And thank you also for this outstanding presentation. I think I loved your approach to look for the unsuccessful cases. These are very difficult patients, and also to present us such a disaster case. What we have to admit is that we can say that the endoscopic vacuum therapy is in general a game changer. So it is already a life-saving therapy, but for sure there are still very complicated situations. My question to you is, what is your approach now? We have the sponge available, we have the VacStent. The VacStent is relatively expensive, so what is the indication for the moment for you to use the VacStent?
So if we have an indication like I discussed, so our primary therapy is the sponge. The standard in our hospital for such patients, when they get the trimodal therapy, so they are treated radiochemotherapy, they get resection, and the high-risk patients, we do the intraoperative placement of the sponge already. This is not standard, this is for the high-risk patients. For all other patients, we do a jejunocat at the same time of the surgery, and we put a nasogastric sonde just to put away the pressure from the stomach and also from the anastomosis. Because pressure means there is not a good perfusion at the anastomosis, and perfusion is probably the most important point to have healing at the anastomosis. So that's what we do standardly. If we have a problem, then we try to get them early. And then our first approach is to put a sponge. And if we are not successful, as I showed in our patient, after 2 or 3 sponges, we see that it doesn't go into the right direction, then we put the stent, actually. This is so how we approach it.
I think what you also showed nicely in your presentation, that we have not enough data, and I'm very grateful to Jacques' group, who started now with prospective trials, and tomorrow, I want to admit this, there is the Young Talent Award, and Lisanne Patinama will also show her the results about the preemptive VacStent placement to prevent anastomotic leakages. So this is for tomorrow. Thank you very much, and congratulations for this outstanding presentation.